Welcome to the National Headache Foundation's new Daily Persistent Headache webinar. Today we are joined by Dr. George Nissan from the Comprehensive Headache Center at Baylor University Medical Center. Dr. Nissan specializes in early diagnosis of migraines and other headache disorders in patients ranging from adolescents to adults. Dr. Nissan, thank you for joining us.
Thank you. The title of this is New Daily Persistent Headache, and it's kind of an interesting title because when we look at primary headache disorders and we think of things like migraine, tension-type headaches, atypical headache patterns, sort of new daily persistent headache is one of the it's a newer diagnosis over the last 20 years or so. And the typical definition that we see with new daily persistent headache is that it's a headache that comes on literally in one day and it just doesn't go away. And people are almost always able to describe, they'll say on March 16, 2010, I had a headache and it hasn't gone away. And it's different from someone who, let's say, has had migraines or tension-type headaches and basically had maybe one a month or so or one every few months in adolescence or early childhood, and then gradually, progressively got worse until their 20s and 30s, and they eventually had what's called a chronic daily headache. So this is kind of a unique type of headache, and it really means a headache of at least 3 months is daily or almost daily. And almost every case, there's really no break from the pain. So usually people can clearly identify the day that it happened, and then they can decide, they say that this is the day it happened. I haven't had any headache-free days since the onset. One of the hypotheses of what causes this type of headache is that we think that there's a fairly good percentage of the population that has a viral trigger for it. So for instance, someone who has diarrhea-type symptoms or viral symptoms like what looks like the flu, and their symptoms start resolving, but then all of a sudden they wake up the next day and there's a headache there and it doesn't go away. So if you do a really detailed history, you can sometimes extrapolate that. But that occurs in about 40% or less of these types of patients. So sometimes you really can't identify the trigger and it just sort of comes out of nowhere in someone who's completely healthy. And there's a lot of debate among headache experts as to how do you appropriately work up a patient who has a new daily persistent headache. And we typically treat it pretty seriously. We do things like MRIs of the brain as well as sometimes an MRA of the brain. Usually the patients that have this don't have a strong family history of migraine, although they found that in some limited studies that occasionally you will see that some of the patients that develop new daily persistent headache ultimately later on down the road will have migraine. So there's a good chance that a patient almost is pre-programmed to have these types of headaches, and they actually are true migraineurs later on in life. So they may not have manifested their migraines early, but they will get them later on at some point. The typical course of new daily persistent headache is very variable. So you'll sometimes see patients that have these headaches for several months and then they just start getting better. Others can have them for months and years, and there's multiple different presentations. You could see it in men and women. You could see it basically from any age group. I've seen it in kids as young as 10 or 11 and adults as old as 80 years old. So there's not a prime patient that you're looking for because pretty much anyone can present that way, although most patients are in their 20s and 30s, and you still see more women than men that have it. There's not a genetic basis to this, so sometimes when you do a history of, I always ask the genetic basis to see if someone's mother, father, or son or daughter or cousins has a history of migraine or chronic headaches, and a lot of the times you won't see it in patients with new daily persistent headache, which is kind of unique because in migraine it's heavily persistent. Up to 80% of migraine sufferers have a first-degree relative that has migraine as well. So this is a little bit more of a challenging type of thing. A lot of people are, prior to getting this type of headache, just have been in a total, they have normal history, no major, medical issues. Most of the time they're young and healthy. So when this comes on, a lot of people will start treating it with things like over-the-counter analgesics like Excedrin, Tylenol, Advil, Aleve, things like that, or generic formulations of them. If they keep doing that and they have a headache every day, within about 2 or 3 months they'll start developing rebound headaches on top of the new daily persistent headache. So usually by the time they present to a headache specialist or someone who really limits their practice to headache patients, they're almost always rebounding with this type of headache. So some of them are actually already been seen by other neurologists or other types of physicians, and they've already been on other meds, and they're overusing the acute medications as well. So things like triptans or gotamines and things that you normally are limited to 1 or 2 days a week, they're taken every day or almost every day. It's sort of an inevitable thing that happens over time. There's really no, when patients ask me about, they all want to find out essentially what is the cause of this headache. And when we do a detailed history, sometimes we really can't find it. And I think that it kind of frustrates patients in that it's not like migraine where they know they've had it all their life. And basically over time, they just know that it may get worse and progressively become more chronic, so they know what to expect, because this headache sort of hits them out of nowhere. And it really is a big problem for some patients, because you get symptoms that are similar to migraine but not exactly migraine, and you also get symptoms consistent with tension-type headaches. So there's a lot of different variables to the presentation of this, and it could be severe, it could be moderate. You could have nausea just like a migraine, and some people just have light sensitivity or sound sensitivity or both of them, but they don't meet all the requirements for migraine. So they can be pretty significant as far as incapacitating type of pain. And it's not, people make the mistake of thinking that this is just a tension type headache, and a lot of times it does have manifestations of migraine too. So there's a lot of different ways that people show up in the office. And what I usually ask patients when they first come in is, how is it affecting their quality of life? What's their level of functionality with it? That's really an important thing from a headache specialty side, because we need to know like what impact this type of headache is for, if someone's having only a 3 or 4 level headache on a scale of 1 to 10, a lot of times they're functional, but if they're running 6, 7s, or 8s on a daily basis, then they periodically spike up to a 9 or a 10, that could be very disabling for the patient. So those are the kinds of things we look at, is the timing of the headaches, how severe are they, what's your level of functionality, what's the family history look like, what kind of neurological workup you've had, like MRI, MRA, things like that. And there's really not a lot written in the literature about this. So we're using mostly anecdotal evidence, meaning that we go by clinical experience and what we've seen in the office. In a headache specialty site, like where I'm working at, I'd say probably a good quarter of the patients with chronic daily headache may present this way as a new daily persistent headache. So it's not a small amount of patients. It's just not as common as episodic or chronic migraine is. So when we do a history, one of the things I always look at is timing of it, because you want to know exactly what the onset of the time, did you have headaches in childhood? Did you have headaches in early adolescence, like women with their menstrual cycle? And then it's most likely not a new daily persistent headache. So it's there's just some key info that we look at with this type of headache. And there's multiple, there's a lot of different ways that we go about treating it. A lot of times we use the same medications that we use with migraines. So some of the meds like the tricyclic antidepressants, the anti-seizure meds, those kinds of things are still considered first line for new daily persistent headaches. There's no like magic pill for this type of headache. So you're basically looking at, going about each patient, looking at them one by one, looking at the age, looking at what type of medications you've been on before, what kind of side effects you've experienced, and then you have to tailor the plan accordingly. And I think because I know there's been some questions already being asked, and I'll probably stop here. If you guys can start giving me the first one, then we can go into some more detail.
Yes. Our first question comes from Barbara. Is there a definitive test that can be given to get new daily persistent headache as a diagnosis, or is it just by ruling out all other disorders?
Yeah, that's a good question. There's no definitive test. You really go by history only. When we're in medical school, the first thing they teach us is take the history. 99% of your answer is in the history. And with new daily persistent headache, it's 100% of the time, because if you don't get a detailed history and find out what happened, like what were the precipitating events or the triggers to this, you won't know your answer. You have to find out from the patient. You can do all the testing in the world, from MRI, MRA, blood work. We look at hormonal levels, things like that, and most of the time everything is going to be normal. So it's mostly, I wouldn't say it's a diagnosis of exclusion. It's more of a historical diagnosis, and then it's confirmed by negative tests. So most of the tests, because, for instance, if someone has a tumor or an aneurysm or something serious, we know that's the cause. It's called a secondary headache. New daily persistent headache is a primary headache disorder, meaning that there's no underlying cause of it.
Thank you. Our next question from Anne. What constitutes a new daily persistent headache? I wake up every day with a headache, but it sometimes dissipates during the day, but not that often.
What constitutes it is basically the onset of a daily headache, which it should not break. So typically when someone has a new daily persistent headache, it starts one day, it's an identifiable day, and it doesn't really break, meaning that you wake up with it and you go to sleep with it. Some people occasionally do get better as the day progresses, but the headache never really goes away. So they might have like a 5 out of 10 level headache during the morning when they wake up, and it may oscillate up and down and maybe be even as low as a 1 or 2, but it generally doesn't go away during the day. So typically it's not, in order to be called a new daily persistent headache, you have to have an acute, abrupt onset of a daily headache. Usually within, the daily headache should start within 24 hours of the first headache, meaning that if you have a headache one day and then you don't have another headache till a week later, that's not a new daily persistent headache, even though you might have had more than 15 headache days that month. So you have to have 3 consecutive months of a daily headache, and then you also have to have either nausea or light sensitivity or some type of other symptom associated with it. But that's also not written in stone.
Our next question comes from our Twitter follower, Karen. What are the similarities and differences between migraine and new daily persistent headaches?
Well, yeah, I talked earlier about the migraine symptoms. Typically, in order for a headache to be called migraine, you have to have light and or sound sensitivity, nausea and or vomiting. The pain should be moderate to severe in intensity, so like a 6 to a 10 on the pain scale. And it should also be incapacitated. It should reach the level of almost being disabling. New daily persistent headache can have a lot of those features. So you can have severe pain of a 7, 8, 9, or 10, just depending on the time of day. You could have light sensitivity. You may have sound sensitivity. You may even have smell sensitivity. You can also get some dizziness, which you also see with migraine. And you can also get nausea, usually not vomiting though, but mostly nausea is what you see. So there are definite overlaps between the two headache disorders.
Thank you. Our next question comes from Facebook. What are new techniques or medicines that can be used to effectively abort a new daily persistent headache?
There's not a specific medicine, because most of the treatments that we use it's mostly things that we use for migraine and what we call status migrainosus, which is an unbreakable migraine for 72 hours. So occasionally we will have to hospitalize patients with this type of headache when they're not getting relief from the prevention side. There's nothing FDA approved for new daily persistent headache, and in fact, it's only been a new diagnosis that I think the federal government just recently recognized about 6 years ago in 2006, when they reclassified the diagnostic criteria for chronic daily headache. And they actually made new daily persistent headache a separate diagnosis. So a lot of the things that we do are really based on anecdotal evidence, and we don't really have that magic pill to say that this is what you take. And in fact, if you have 10 people with new daily persistent headache and they're all the same age, you're probably going to treat all 10 of them differently, with the ultimate goal of trying to either break up the headache cycle or getting the headaches under good enough control where they do not interfere at all with your life. So, when we look at things like we decide with preventive medications, just like we would use in migraine, we also will use acute medications for severe increases in the pain level that might occur throughout the week. And then we'll also do lifestyle modification like biofeedback, physical therapy, nutrition counseling, things like that. There's a lot of different ways to approach it. And then specifically, if they don't respond to medical or unconventional therapy, we'll sometimes have to hospitalize the patients.
Thank you. Our next question is also from Facebook. This is from Janet. She says her husband has had headaches for 3 years now, and they sound like they're new daily persistent headaches. They've been to the medical doctor, 3 neurologists, and also a pain management specialist with no improvement. He's had headaches before. He has also had an ultrasound, an MRI, a lumbar puncture, and numerous other tests with no explanation. These headaches are sometimes debilitating and at times not so harsh, but persistent day after day. Does this sound like a new daily persistent headache?
Yes, this can be. When you have, if it came out of a situation where there was no prior childhood history or early history of headaches, this could be, if it literally just started out and was daily from day number 1, that could definitely be a new daily persistent headache. And most of the time, I'd say 99% of the time, you're going to have a negative MRI, MRA, lumbar puncture, nerve conduction tests, and all those different neurological tests are available to the public. It will almost always be normal. So you really got to look at the history. As we know from the testing, it sounds like that everything was negative. You just got to really go by what the history is. And there's sort of an overlap because some people actually have chronic daily headache and think that they have new daily persistent headache. And chronic daily headache, in order to be called that, has to be started with some form of early headache sometime in the life, and it's usually in childhood or teenage years. If the person is someone who had no prior history of headaches when they were younger, and all of a sudden they start having a daily headache out of the blue, and sometimes you can trace that viral event and sometimes you can't, but that's really where you go. So I would say purely from a historical basis, if that's the way that he presented, then it would be new daily persistent headache and all the other testing is negative, which is very similar to the majority of new daily persistent headache patients.
Our next question comes from Scott. Is there a link between migraines and heart valve conditions?
You know, there have been studies going back almost 13 years now on what's called the Peyton, Foramen, Ovale, which is it's kind of a conduit for delivering nutrients from the mother to the placenta during pregnancy. And for some people, about 10 to 20% of the population, nationally and internationally, there's a failure of that to close after delivery. So that's called a foramen ovale. When it stays after delivery, when the child is born and it's patent again, stays open, it actually is called the Peyton foramen ovale. And there was what we thought was a link to migraine and Peyton foramen ovale, but what we've really proven over the years is that Peyton foramen ovale, even if someone has that and they're found having it, the only way to diagnose it is by a cardiology echocardiogram bubble study. And that's the only way. It's a very specific type of test that you have to do. And essentially, there is a link to some people with migraine. I guess the best way to describe it is that people with migraine have a higher prevalence of it than someone who doesn't have migraine. So when they first discussed this in England, this was a while ago in the late 90s, they talked about closing the Peyton foramen ovale and hoping that it would help the migraine. The only time there's been debate in the United States as to whether to do that or not. And what we found is that the only time I've ever referred a patient to get it closed is if they have what's called complicated migraine, which is a migraine that's associated with what looks like a stroke, where the person has paralysis, slurred speech, weakness, or just general Lyme. They literally look like a true stroke, and they're worked up that way as a stroke, and the symptoms resolve after the headache goes away. And there's been statistics to show that you can reduce the risk of stroke by closing the foramen ovale, the Peyton foramen ovale. So in those cases, we would recommend getting that worked up. But for general chronic headache patients, it's not recommended to do an echo with bubble study.
Anne would like to know why a headache can be worse when lying down, but better when up and moving around a bit.
Well, a headache can be worse when lying down. Sometimes, it kind of reverses. You would think that most people feel better when lying down and then are worse when standing up, but it can present, cerebrospinal fluid leaks, where there's an actual leak from the spinal fluid, whether it's from an epidural, like someone after they deliver, usually has that where someone feels like they want to lay down because they feel better, and then they feel worse if they sit up or stand. But this is kind of an opposite, and we don't really know the physiology of why that is, but some people do prefer the standing position. Particularly people with cluster headaches, for instance, actually prefer to stand and rock back and forth rather than laying down. Laying down actually makes them feel worse. So it's in contrast to someone with migraine who typically feels like they want to lay down in a dark, quiet room. So it's not usually a spinal fluid leak that leads to those type of symptoms. And when we think about migraine, it can present so many different ways, and there's some people do worse in the daytime, some do worse at night, some have it one-sided, about 90% have it one-sided, the other 10% have it two-sided, just like a tension type headache, and you can have reversal of some of the symptoms. So some people actually feel worse laying down than they do standing up. And I always ask them when I first see a patient is, what makes you feel better when you have a headache? Do you prefer to lay down? Do you prefer to stand up? Do you prefer to walk outside? Those types of questions. And they usually are pretty good about knowing what makes it feel better.
Our next question is a Facebook post from Michelle. Are there any new preventative meds recommended for new daily persistent headaches?
That's a good question, too. Almost all the meds we use for new daily persistent headache are the older meds that we have data for their use in migraine and chronic daily headaches. So typically when you look across the board, the meds that have the best effect on new daily persistent headache are the old tricyclic antidepressants, which are the least expensive drugs on the market. Amitriptyline is the conventional one. It costs like $2 to $3 a month for a month's supply. Then there's also nortriptyline, doxepin, imipramine, disipramine, protriptyline, those types of medications. They're all available in the generic form. The other route is the anti-seizure meds, which are also, some of them are FDA approved for migraine, like Topamax and Depakote. And then some of the off-label anti-seizure meds that we use are Zonegran, Keppra, things like that. So there's no specific new, when we look at the research in migraine and chronic daily headache, most of the medications are currently available drugs that we were using off-label anyway. So whenever something new comes out, like an anti-seizure med, for instance, headache specialists are almost always the first to use them because we want to know what its effect on migraine would be or chronic daily headache. And a lot of times they can translate well into new daily persistent headache. So there's been a few anecdotal studies, meaning that clinical-based studies that found that maybe doxycycline, which is one of the, they use it for acne. It's a typical antibiotic. It can also be used for UTIs, urinary tract infections, upper respiratory infections, that may be combined with a drug like Topamax or an antidepressant like amitriptyline. And it has sort of it's an anti-inflammatory type of effect, and you can kind of mix them together. But that also hasn't really been proven to the general population. And I generally don't like to mix antibiotics into the regimen because you can breed resistance. But those are the kinds of things that we look at. There's no, unfortunately, even for chronic migraine now, we're not really seeing a lot. The last drug that got FDA approved for migraine was Topamax. That was in September of 2003. So we're 9 years down the road now. We have nothing new. And then when we look at acute medications, I don't know if you guys had read today in the Wall Street Journal, there was a great article on research paths in migraine, and one of the things that was on there, they talked about the CGRP antagonists, which are calcitonin gene-related peptide blocker medications, and two companies that had come out with these are actually acute medications to treat acute migraine, and they thought it might be a substitute for the conventional triptans like Imitrex and Zomig, things like that. And what they found is that it worked fine, but the problem was that there was a small percentage of people that had liver toxicity. And Merck and Boehringer Ingelheim are the two drug companies that had good results overall, but they had these safety issues, and they effectively pulled off the market, so we will not see these. And only one company, which is Bristol Myers Squibb, is looking to potentially research more into it. So right now, almost everything we do in migraine is modification of currently available treatments. So things like, delivery systems. I know some of you guys are probably familiar with Ovale, which is a needleless injector of Imitrex. There's nothing novel about it. The only difference is that it's a needleless injector. So some people prefer not to have a needle, but they're just taking what's currently available on the market and modifying the delivery system. So it's not really adding to the science or the physiology. And one of the things that the article talked about in Wall Street Journal was that the next phase of acute medications for migraine are going to be biological antagonists of the CGRP system. So effectively what they're going to look at is if they can find these antibodies that can bind to this protein marker in the brain and stop the release of CGRP. And that may be promising later on down the road, but that's honestly the newest thing, and we're still years away from it as far as ever seeing FDA approval of that type of medication.
Barbara would like to know, have you seen any success stories with acupuncture for treatment of this condition?
That's also a good question. I do like alternative treatments like acupuncture, massage therapy, and physical therapy. There is a role. I have seen people combine that with medical therapy to use to get their baseline level of pain down with preventive medication, and then on top of it do acupuncture weekly or even more than weekly to bring it down to very manageable levels. So I think that acupuncture is a good choice if you have someone that knows, that really has dealt with headache patients before, is comfortable with it. I think combining that with massage therapy and physical therapy can be a benefit, and it's great in that it's not as invasive, and you basically may get some non-medication benefits from these types of treatment plans. So when we're trying to figure out how to go about a patient with new daily persistent headache, I'm typically open, and most headache specialists are open to all kinds of treatments, and acupuncture certainly is a possibility.
Looks like we have a Facebook post from Jen. She wants to know if you have any recommendations on how to cope with new daily persistent headaches during pregnancy.
That's a great question. We see this a lot in the headache specialty side. Pregnancy poses a lot of problems for a headache sufferer because especially if it's someone who truly has new daily persistent headache and goes into pregnancy and starts developing headaches for the first time on a daily basis, which can be very difficult because, as we know, most women with pregnancy during the second and third trimester almost have complete remission of headaches. It's typically the most stable time for women with migraines, and they'll usually say that after delivery their headaches can come right back. So they usually like the pregnancy stage, but I have seen some cases of new onset, new daily persistent headache during the first and second trimesters of pregnancy. I typically refer patients out to do biofeedback, some physical therapy within their means, and also working on stress relaxation because you are very limited. There are only a few drugs that you can safely use, or actually not, I wouldn't even call safely used during pregnancy, but have a better safety profile than some of the other meds out there. That's some of the things that we've dealt with, some of the high-risk OBs as well. If someone has more difficult daily headaches during pregnancy, how to go about mixing traditional and non-traditional methods. And I usually do focus more on, I think, biofeedback and stress relaxation and massage therapy and things like that have the best benefit for pregnant women, and hopefully will help with pain coping skills. Because that is probably the most difficult time for any headache sufferer, since they can't take most conventional medications, especially during the later phases of the pregnancy.
Our next question is from Barbara. Is a nerve block an effective treatment for new daily persistent headaches?
Nerve blocks are commonly used in conjunction with regular medical therapy, and depending on where the location of the headache is, if you have a very localized area like the occipital nerve in the back of the head or the supraorbital nerve, which is above the eye, if you can really localize your pain to one area, sometimes you can get transient relief with nerve blocks. And then there's also something called a rhizotomy, which is where you actually burn the area around the nerve, and that's a longer lasting relief for some patients. And a lot of times we'll use nerve blocks in conjunction with regular medical therapy to get control. So I wouldn't say it's not FDA approved. I mean, all of this is in conjunction with the medications, but we do use that, and I have sent patients to do the blocks before, and sometimes they really do get some relief. If they have more of a what we call holocephalic headache, meaning that it hits the front, back, sides, and everywhere around the head, there's no area to localize, like the right side or the left side or the front or the back of the neck, then it's a lot harder to recommend something like a nerve block, because you really get the best benefits with on the nerve block side is when you have a localized area to inject. There's also people have been asking questions all the time about use of Botox with new daily persistent headache. Botox is FDA approved for chronic migraine, meaning that you have more than 15 migraine days per month out of 30. So essentially, new daily persistent headache potentially may benefit from that too, even though it's not specifically a migraine type headache. But if someone has a more diffuse headache in both the front and back of the head, and you can localize, give the 31 injections of Botox, sometimes you can get better benefits than doing a localized nerve block. So there are some options like that, and it really just depends on the location of the headache.
Our next question is from Julie. Is there a relationship between new daily persistent headaches and conversion disorder?
Well, conversion disorder is where someone has a symptom that is basically converted into something else. So for instance, someone that is having anxiety and then they convert it into back pain or head pain. And usually what I've seen, and there is some relationship to it, but most patients with new daily persistent headache are not conversion disorder patients. And the majority of them have they are really literally wake up one day and have this headache come on out of nowhere. We see more conversion in people with transform type of headaches where they start out episodically throughout their life, and then all of a sudden it becomes daily one day. So it's really hard. You got to do a fairly detailed history, and it's a great question. It's one of those puzzles in medicine as to whether how strong the mind is to convert from one disorder to another form of pain, that the mind can play tricks like that. So I usually assume when a patient comes in to see me that they're not having conversion disorder and that what they have is real, and then I go more detail into the history to find out what brought it on and what else was going on in their lives. A lot of times we do get psychology involved to help with some of the testing on that, and I very rarely see conversion disorder with this type of headache.
Our next question is from Anne, and she'd like to know if there are any analgesics that aren't metabolized through the kidneys. She says that other than acetaminophen, because that does nothing for her headaches, she has only one kidney, and the nephrologist that removed her other kidney stated that she must be sure to never use NSAIDs or other pain relievers that might stress the remaining one.
That's a good question too. There are people with daily headaches that have either one kidney, or some of them have had kidney failure or on dialysis, and we do see a fair amount of that too. There really is extreme limitations on someone with kidney disease in using or choosing an analgesic. Tylenol also causes rebounding when used in excess, so you got to be careful with the acetaminophen type products. You can use some muscle relaxants that don't metabolize through the kidney, and they may or may not work, and that's sometimes an alternative to the analgesics, because when you can't have NSAIDs, and that also includes people, for instance, that have had gastric bypass surgery, that their surgeons will not allow them to have NSAID or non-steroidal anti-inflammatory drugs, because it will, they already have had these issues. They don't want anything going through the stomach that can irritate the stomach lining. And same thing with gastric sleeve patients too. So this question comes up frequently, and we usually have to use off-label medications and really test them out. There's unfortunately no cookbook answer to it. So we use things like muscle relaxants and some atypical type of treatments in those patients, because you got to be really careful. Just like with a kidney patient who can't take NSAIDs, there's a lot of other, the new advent of all these abdominal surgeries that have come out for weight loss have really changed the way we approach acute treatment.
Our next question is from Alexa. She states that she's had an MRI but not an MRA. You did mention MRA, and she'd like to know how it's used in diagnosis and treatment.
The MRA is a magnetic resonance angiogram of the brain, and the difference between an MRI and an MRA is that the MRI looks at the brain tissue itself, or look for things like brain tumors, strokes, bleeds, those kinds of things. The MRA actually looks at the blood vessels that innervate the brain, so they don't actually look at the brain tissue. The patients that we usually get to do MRAs are those that may have had a family history of aneurysms or a suspicion in their headache that it could be a blood vessel-mediated disorder that's what we call a secondary headache disorder, meaning that the headaches are due to another reason. So I don't send a lot of the patients to get MRAs. It's really more based on the history, including the family history, but also the presentation of the headache. So not everyone with new daily persistent headache has to get an MRA. And in fact, even getting the MRI, it's recommended by experts to do that because we're always worried when a headache comes on suddenly and is new that it could be something significant. But even out of all the MRAs that we order, almost always they're normal to near normal with new daily persistent headaches. So it's more based on the history. It's not a generalized edict to say that everyone with new daily persistent headache has to get an MRA of the brain in addition to the MRI.
Sean would like to know, do you have any suggestions on how to keep a migraine diary when you have headaches every day for most of the day?
That's a great question. I still make my patients do a log, and what I want to know on the logs I look at with each visit is that I want to see what's the most severe pain they had for the day, because we know they have a headache every day. What I'm looking for is based on that person's subjective scale, from a scale of 1 to 10, I want to know what's the highest level of pain you reached that day and what time was it. So if you felt great in the morning and your headache was a 2 when you woke up, then you went to work or school and the headache starts spiking, I want to know when that spike occurred and how high it got. So all I'm looking for is one number on a scale of 1 to 10 and what time it occurred. And that can help a lot to see, to learn when is the time that you feel the worst, when is the time you feel the best. Are there any things that bother you environmentally? Like, do you have any triggers in the environment? You know, a lot of migraine sufferers feel that when there's thunderstorms coming on, they can feel it 12 or even 24 hours earlier. So that's important too, is I want to see what the weather looked like before the headache spiked. Things like foods, which are not as clear-cut as triggers in someone with new daily persistent headache, but if you can identify something, or drinking wine or some unusual thing that happened that day, that can always help the headache specialist, because we're not, one thing I always tell patients is that we can't read minds, and we can't look at someone's forehead and say, hey, your headache's a number 8 out of 10 today. So when we look at a calendar over a month or 2 months' time, seeing what the trend is throughout the 24 hours is very helpful to us to see when the patients feel the best and when they feel the worst, and were there any external triggers that made the headaches worse on certain days. And also things like periods, because it's bizarre, but sometimes with a daily persistent headache, someone can still have worse headaches during their period, almost like a migraine. When women have menstrual migraines, but in younger women with new daily persistent headaches, sometimes you'll see a menstrual component of worsening pain during those menstrual days. That's on top of their normal baseline pain.
Let's see, our next question is from Mary. How typical is it to pass out with headaches?
Passing out or having a fainting episode with headaches is very infrequent or not common. Most patients will feel some form of dizziness, or some will feel vertigo, or the room feels like it's spinning around them. Dizziness is more where you subjectively feel dizzy and the room is actually not spinning around you. So there is a difference between vertigo and dizziness. Actual passing out where you fall on the floor is very, very rare, especially with a new daily persistent headache. There are some headaches called basilar migraines. That's the old definition. Now we call them complicated migraines that do involve actual passing out or fainting episodes during the most severe point of attack of the migraine. And those patients are very, very uncommon. So out of all the percentage of migraine sufferers, probably 1% or less have complicated migraine disorders. So when you look at, there's about 36 million migraine sufferers in the United States. So you got about 12% of the population. If you look at the census of 300 million, you're talking a tiny amount that actually have complicated features to their migraine or passing out episodes associated with them.
Thank you. Our next question is from Becky. Are there any clinical trials for new daily persistent headaches?
Great question. There are not any national headache trials for new daily persistent headache. It's hard enough to get people, or to get companies to sponsor trials for just episodic migraine, which is where all the pharmaceutical companies typically devote most of their research to people that have 15 or less migraines a month. Those are the drugs that are the easiest to approve and have the most benefit. When we look at a daily headache patient and we look at long-term prevention, almost everything that we do from clinical trials is extrapolated from the migraine studies. So there's just not enough patients per se to have it, unless a headache specialty center gets specialized funding from the government to do a study like that, which is extremely rare because if you look at the funding from the NIH for migraine studies or chronic daily headache studies, it's a very tiny percentage of all the money that's divided out. So a lot of the government studies and the pharmaceutical studies are devoted more to things like diabetes, cancer, stroke, things like that. That's where all the big dividends pay off for them. So when we look at headache patients, new daily persistent headache, I mean, in all the years that I'd worked both in Chicago and in Dallas now, I've never seen a study just devoted to new daily persistent headache because there's just not enough patients to bring into it that will meet all the criteria and fit that diagnosis perfectly. So, unfortunately, if someone has a new daily persistent headache and they want to get into a migraine trial, they'll be excluded because most of the migraine trials require it to be a true migraine. It's usually less than 15 per month.
All right, Sherry says she's had new daily persistent headaches all day from morning till night for the last 32 years since she was 26 years old. It is medicine resistant and she's tried everything and had tons of MRIs and CTs. It runs at least a 6 to 8 on a pain scale, plus she has at least one migraine per week. Her migraine medicines don't touch her migraines. Is there any way to stop these headaches or help them to let up?
Good question, and it's very rare for someone to have a new daily persistent headache that goes into decades. When we think about new daily persistent headache, and I've seen some patients that have had it that long, but for the most part, most of them do eventually start getting better, and that is a very difficult question to answer when someone has them for 20 or 30 years at this point. And it is sometimes when you talk about a baseline pain level of 6 to 8 on the pain scale, that's a pretty high, that's almost migraine level right there. When we look at the definition of migraine, it's typically a moderate to severe pain level, and I would call moderate like a 5 or a 6 on the pain scale. So that's someone who has new daily persistent headache with migraine level ranges of pain, and that's a very difficult question to answer, and I would have to look into detail on the patient's history and what they failed and what they've done well with, because in a case like that, you really have to think outside the box. And you may have to try some alternative treatments because there's no cookbook answer. What I always tell patients is that a new daily persistent headache is not like cardiology. If someone comes in with a heart attack, for instance, to give them aspirin, a beta blocker, and you take them right into the catheterization lab, and you may do an angioplasty instead. It doesn't matter what the age of the patient is. If you go based on the presentation, but if you have someone with chronic daily headache or new daily persistent headache, you're going to approach each one of them differently with the same intent and outcome. So there's no cookbook answer to, you can't just pick up a textbook and say, okay, this person failed A, B, and C, now go to plan D. It doesn't really work that way because there's just really so many different ways, and probably if you polled 10 different headache specialists, all 10 of us would have a different approach to treating this specific case. So there's no real, unfortunately I can't give you a real answer to it, but I would say for someone like that who's failed, they really need a more intense program, actually probably a more multidisciplinary treatment program in one of the tertiary headache centers to really get evaluated, especially at this stage in the game after it's been lasting for so long.
Mary would like to know, can you have a brain aneurysm and still have new daily persistent headaches?
Technically, by definition, yes, if the aneurysm is not the cause of the headaches. Meaning that if you get the aneurysm clipped and the headache is still there, then the aneurysm typically is not the cause of the headache. Or if someone has a stroke, for instance, and they have just an ischemic stroke, meaning that they have loss of oxygenation, not an actual aneurysm, and they can have chronic daily headache associated with that. But for it to be called new daily persistent headache, it has to be an entity in and of itself, not related to the other disorder. So headaches that are caused by an aneurysm or stroke are not new daily persistent headache. They would actually be called chronic daily headaches. So it really is all semantics. And that, if someone, for instance, had new daily persistent headache for years and years and always had an MRI that was normal, and then one year they get up and they have what looks like a stroke, and they actually have a stroke on their MRI, then we know that the stroke is separate from the new daily persistent headache. So it's only cool from the headache rule perspective to make a diagnosis like that. But if you want to be a purist, actually, to be called new daily persistent headache, you technically should not have any of your symptoms caused by an aneurysm or a stroke. That would be a chronic daily headache.
Our next question is from Alexa. You mentioned that patients that don't respond to medication or other types of treatment, if patients don't respond to medications or other types of treatment, you may hospitalize them. What happens during the hospitalization?
Um, Typically during the hospitalization, we use IV medications on a continuous basis every 4 to 6 hours, pretty much scheduled around the clock. And then in most headache centers nationally, we use more of a multidisciplinary approach where we use biofeedback, physical therapy, nutrition, stress relaxation, things like that. So those patients that I would normally consider and some of the other headache specialists would consider to be hospitalized are those that really are less functional because there's someone that's failed numerous different types of acute medications in the oral or nasal spray form, and they're just not, some people don't tolerate preventive medications really well on a daily basis. So those are ones that you may want to take a more aggressive approach, and there's also dispute on that as to whether someone needs to be hospitalized or not. And I typically, when I look at the criteria for who goes in, I really look at levels of functionality and how well the patient is doing. If they're not functional and they're not able to do the things they want to do, sometimes I would consider hospitalizing them and use IV medications. Typically, you want to use non-narcotic type of meds because those just cause rebound headaches. And if you have a new daily persistent headache, typically the narcotics will just essentially, they'll mask the pain for about 6 hours or so. Then every time the drug wears off, the pain will come back. So you want to use a non-narcotic approach, and you want to do it in a fairly rapid pace where you give several meds in a day repetitively over and over to see if you can disrupt the headache cycle.
Our next question is from Julie. She'd like to know what your opinion is about occipital and supraorbital stimulator implants for new daily persistent headaches.
That's a great question. We've had a lot of patients ask about the stimulators. There's a lot of media attention going in. In Dallas, there's several doctors where I'm at that actually have huge billboards on the expressway that talk about it. Says, do you have migraine or do you have chronic migraine? And then ask your doctor about neurostimulator. They actually have the doctor's picture on the expressway. So it's gotten big media press. The question is whether those things actually work. And from my experience, and I'm not discouraging people from getting one, but from what I've seen is that it's sort of a placebo effect where people will get the stimulator put in, they get the electrodes placed, and they may feel good for a while. It'll bring down their baseline level of pain, but over time, and it could be weeks, it could be months, most of the patients I've spoken to have said to me that the pain starts coming back to where it was before they got the stimulator. So you really want to reserve that for patients who have taken every step they possibly could for treatment and have legitimately failed everything that's out there from the prevention side and have utilized all the techniques, are not overusing medications, and are good candidates for the neurostimulator. I have only recommended a handful of patients in my entire history of doing headache, and those are very select patients. And even the ones that I've referred usually don't do that much better on it. So I really would, if you're someone who's considering doing that, you need to do your research on it. It's still not FDA approved for chronic migraine, so it's really, if you look at the data, it's all for occipital neuralgia, which is not what new daily persistent headache is. This would be an off-label use of it, but it is a possibility, and some people do go ahead and do it, and it's really more for, I would say, reserve. It should not be something that's first or second or even third line. It should be something later on down the road when multiple different trials have been done of normal meds, standard therapies, and people have failed that are just not gotten better on them. So, the data is clear that there's not enough percentage of people that have benefited from it, but there are some that do. So you really have to be selective, and you have to go to someone that has experience with doing the stimulators and has fairly good outcomes, because anyone can say, oh, I have a 75% success rate, but where's the data to prove it? And so you really need to be careful if you do it, especially for something like new daily persistent headache where there's not a prescribed manner of putting in a stimulator. So you just be doing it off-label and taking a chance that it can help. Now the caveat to that would be if you have purely occipital pain or supraorbital pain, that's the only place that the headache hits, there may be some benefit of using the stimulator in those cases. So those are the ones that I would do, that I would actually consider someone who's failed everything and has very localized headaches.
Our next question is from John. Can overuse of triptans lead to daily persistent headaches?
Overuse of triptans, by definition, yeah, you can get chronic daily headache from overuse, or what we call rebound headaches, which is called medication overuse headache, is a technical medical term for it. MOH, or medication overuse headache, is extremely common, especially in big city headache centers. And that doesn't cause new daily persistent headache. That causes chronic daily headache with rebound headaches. So overuse of triptans, if you take triptans more than 2 or 3 days a week, for instance, which is, actually I usually tell patients not to take it more than 2 days a week, but once you start doing this regularly, within about 6 to 8 weeks, you will start rebounding if you use it 3, 4, 5 days a week. And then eventually you'll get a daily headache out of that. And that's not a new daily persistent headache. That's actually, and once again, it's all semantics, but it's actually a medication overuse headache, which is called rebounding. That's different than a new daily persistent headache, because new daily persistent headache occurs in someone who's never had headaches before, starts getting the headaches, and medications did not lead to their daily headaches. So what you're talking about is a different type of headache, but yes, the answer to your question is yes, triptans can lead to chronic daily headache.
Our next question is from Julie. How can one avoid rebound headaches when headaches are daily and constant? Not treating a headache is very difficult. Non-med methods are generally ineffective.
It's a good question, and I think that to go through, that's a good question. I mean, I would say, from our standpoint, we're always purists from the headache specialty side, and we would do more of telling patients to limit their use of acute medications to no more than 3 days a week. If someone's using something acutely every day, and they raise the risk of rebound headaches, and it happens a lot. Unfortunately, we see that it is not treating a headache is a very difficult thing. When I tell patients that they should not treat when their headache is below a 5, or there's a certain cutoff point that you have, and really, in order to get better from a new daily persistent headache side, you can't be rebounding. Because if you throw the rebounding on there on top of your baseline daily headache, it makes it much more difficult to control. So, basically, it's something that I would not recommend to tell patients, but I understand why they do it. So, you really have to decide as a patient what's your threshold for pain, and so. It's kind of a difficult question to pin me into, because I can't legitimately recommend for someone to overuse medications. I could see their point in doing it, but and I've set thresholds with patients before, and most of the time they're successful by staying within the limits. Doesn't always work, but from what I've seen, even in some really complex cases, patients are able to really change their use of acute medications.
Our next question is from Shirley. What are the differences between cluster and daily persistent headaches? How do you distinguish between the two?
The differences between cluster and new daily persistent headache, yeah, that's easy to tell. Cluster headaches are very specific headaches where they typically occur. When you use the term cluster, you're looking at a very specific headache. It usually is a headache that occurs on a seasonal basis, usually in the fall or spring. It typically lasts for about a month, where you have 1 to 3 headaches per day. They last about 30 to 45 minutes per day, and they're almost always associated. They never move behind the eye, or they never change. So if you have it behind the right eye, it never moves from behind the right eye, and it's associated with tearing from that eye, nasal drainage from the same nostril on the side of the headache. So if you have a right eye headache, it would be tearing from the right eye, nasal drainage from the right nostril, and droopiness of the right eye. It usually goes away within about 30 to 45 minutes. They can come back a few times a day. About 90% of patients have it episodically, meaning that it only occurs for a month or 6 weeks per year, and it doesn't come back for the following year. 10% have it daily, and those are very, very rare to see. New daily persistent headache is a continuous, nonstop headache that does not have things like drainage from the eye, drainage from the nostril, tearing from the eye, or droopiness of the eyelids. It's a very specific type of headache. And so that's really where, when we look at the history, this is where history is key. And what I was saying before is, when you're talking to someone, you're finding out what type of headache this is, their history and their accurate history is the most important thing, because you do need to distinguish between a new daily persistent headache and a cluster headache because the treatments are totally different, completely different from each other. So it is very important, and it's very specific. Most cluster patients are smokers, about 98%. They typically are male and obese, so there's a very specific look that you're looking for, although thin women can get them too. They're non-smokers, but it's rare. So typically you got to look at the age of the patient, what their presentation is, and what type of symptoms they're having with the headache, and it's very easy. Once you see a cluster patient, you never forget that patient.
Our next question comes from Emily from Facebook. Do you recommend diet changes? I know friends who have found going gluten-free as well as watching sugar intake and going dairy-free helps.
Great question. I'm a big fan of dietary changes, and I do really expect that of my patients as well. With migraine per se, we know that eating foods that are low in tyramine or nitrates, so things like avoiding aged cheese, red wine, sausage, pepperoni, salami, things like that are definitely beneficial. We do not know in new daily persistent headache whether that's beneficial or not, although I still have patients follow the migraine diet with new daily persistent headache. Gluten-free diets, it's a big phase it's going through now in American society. A lot of people are on it. I definitely am not against using it because I think there are some definite health benefits to going gluten-free. It doesn't hurt to try it. I've had some patients that were really successful with a gluten-free diet. I think it's great if you can stick with it. I think it's a much harder diet to stick to than a low tyramine diet. It has a lot more restrictions as to what you can eat. So if you go on a low tyramine and gluten-free diet together, which is what you would really need to do if you're a headache sufferer and want to do a gluten-free diet, you still have to follow the low tyramine diet, and you'd have very few things that you can eat, and I think that would be very difficult to tell someone to do that. So I think the better way is to start with a low tyramine diet, and the National Headache Foundation has one of the best diets out there on their website. It basically has every food group, what's allowed, what you should be cautious with, and what you should avoid. It's nicely laid out in columns, which I like because I like things in simple terms like that. I think that's a great start, and if that doesn't work, then you could try a gluten-free diet after a couple months, and I think that would probably be the better way to go because we still don't have adequate data on whether a gluten-free diet is going to be successful in a migraine or chronic daily headache patient. But I have seen some success stories in the clinical side.
Our next question is about family history, and this is from Lindsay. How much do you think the family history has to do with having new daily persistent headaches?
Family history is not as common in new daily persistent headache as it is with migraine. With migraine, there's a definitive link, although, when we look at a new daily persistent headache patient, I still ask about family history because I am curious to see if there is a strong family history of migraine or other headache disorders on mom or dad or first-degree relative side. There still has not been proof that people with new daily persistent headache have a higher history of headache disorders in their immediate family. So it's not as clear as it is with migraine. Just like with cluster headaches, for instance, too, cluster headache does not have a clear genetic component. So a lot of times if you see a cluster patient, they'll have no family history whatsoever. I just did my own internal trial of seeing new daily persistent headache patients, and a lot of times I've seen in clinical practice that they do have a parent or an immediate relative that has a history of migraine. Who may not have had necessarily a daily headache disorder, but had a history of migraine, and the patient was the first person ever to have the daily persistent headache in their family. So I think there probably is, there just hasn't been enough studied on it. Even if you look at the headache textbooks on Wolf's headache and some of the other traditional textbooks that we use in headache medicine, no one really has proven whether there's a strong family history. We think there may be, but I'd say it's probably 30 to 40%, whereas with migraine, you're looking at about 80% history of migraine in the immediate family. So it's a much big difference, or a much larger population in migraine sufferers. So it is important, and I think if you go to see a headache specialist, they're going to ask you, if you have this type of headache, who else in the family has chronic headache disorders. It just helps to also look for other things, and to look for things like, is there a history of stroke or aneurysm? So while it's not as clear-cut as migraine, from what I've seen in clinical practice, there probably is some link in there. It just hasn't been proven in the large population.
Well, Dr. Nissan, I'd like to thank you for joining us. Unfortunately, we couldn't get to all the questions tonight, so we'd definitely like to invite you back in the future. This is a
Great.
great session. I'd like to thank everyone else for joining us this evening, and feel free to join us again on August 21st for the Headache in the Workplace chat. Again, thank you, Dr. Nissan, for joining us, and have a great evening.
Thank you very much. Bye.